Good evening, everybody. Last class, we discussed how the history of the presentation of a child can be analyzed and you could reach conclusions with regard to the pathogenesis of a symptom. And the history, when analyzed in this context, would lead to a proper conclusion, and it will tell you how to approach clinical examination of the child with suspected heart disease. Today, we go on to the actual clinical examination part and how it should be structured so that at the end of the examination, you have a clear diagnosis or a clear clue as to what should you do to reach a diagnosis. You start, of course, with a general examination. It's worthwhile always to assess, is the child comfortable or in distress? You may be encountering a child not necessarily in the examination hall, but in the busy outpatient clinic or in the extremely hectic emergency room. There, you may be triaging a child, and it's necessary for you to realize that this particular child needs instant attention, whereas the other one can wait for half an hour. So learn to understand how the child who is comfortable appears to you and how the child in distress and in dire straits would appear. That apart, you would begin your examination like any other pediatric examination by anthropometry. You want to look at the height, weight, and the head circumference. These are not merely routine measurements to be taken. The height and the weight often give you a clue about the severity of disease. Remember last class, we discussed about failure to thrive as a manifestation of heart disease. Therefore, say you are diagnosed with tetralogy-of-Fallot, you have a 5 kg child at the age of 2 years. It is a very different implication from a well-thriving child weighing 10 kg plus at 2 years. Therefore, anthropometric data is more than simple noting of values. Then, is there cyanosis or clubbing? And make a head-to-toe examination for congenital abnormalities. For example, an abnormal facies, abnormalities of the limbs, polydactyly, syndactyly, webbing of the neck. All these are things which have implication with regard to cardiovascular diagnosis. You are familiar with the classical appearance of Williams syndrome or DiGeorge syndrome or Noonan syndrome or Down syndrome. Remember, there are countless other syndromes and the new ones that are getting described. There are subtle features which you will need to understand to recognize a classical syndrome. Otherwise, at least note that the child has a particular dysmorphic feature, like an abnormal ear and a wider palpebral fissure or some such abnormality which could be noted down, and later it could be noted as a marker perhaps of a 22q11 deletion syndrome, a subtle sign. Any dysmorphic feature therefore merits noting. These finished, you are actually proceeding to cardiovascular examination. In cardiovascular examination, remember your sequence is pulse, blood pressure, JVP, precordium. Pulse, blood pressure, JVP, precordium. Follow this sequence religiously. Let's start with the pulse. What is the pulse? The pulse is a pressure distension wave due to the ejection of blood into already filled aorta, propagated along the arterial walls and palpable in all superficial peripheral arteries. It's a very long definition, but remember it has important components. What is it? It's a pressure distension wave. Why does it occur? There is ejection of blood from the left ventricle into an already filled aorta. How is it propagated? Along the arterial walls as a pressure distension wave. Where is it felt? In all superficial peripheral arteries. So once you break it down into those components, it's easier to remember the definition. The wave itself has components. like the percussion wave, which is the impulse generated by the LV ejection, the tidal wave, which is composed of reflectance waves from the upper part of the body, and the dicrotic wave, which is recoil of blood from the closed aortic valve and reflectance waves from the lower part of the body. Here, this is the percussion wave. Normally, the tidal wave gets superimposed on that, and it's not separately distinguishable. When it is, we will refer to the conditions. And the dicrotic nodes and the dicrotic wave are also not ordinarily palpable. But if you are familiar with a radial artery trace in the post-op ICU, you will find that the percussion wave and the dicrotic wave are always there. In the position of the dicrotic nodes is higher in a central arterial trace, and it is lower in a peripheral arterial trace. So in a radial artery trace, the dicrotic nodes would be even lower. How do you describe a pulse? Rate, rhythm, volume, character, radiofemoral delay, peripheral pulses. In other words, the pulse rate is, let's say, 60 per minute, regular in rhythm, normal volume, normal character, there's no radiofemoral delay, all peripheral pulses are felt. That is what would complete description of a normal pulse. Let's see where the pulse can become abnormal. Start with simple abnormalities of rhythm. We have learned from Hutchison about the regularly irregular and the irregularly irregular pulses. It is regularly irregular when there is an alternate ectopic, or as producing a bigeminy or a trigeminy. Bigeminy means there's a group beating of 2 beats, pause, 2 beats. Trigeminy, 3 beats, pause, 3 beats. When there is a bigeminy, alternate ectopic beats is a common cause, but not the only cause. Remember a 3:2 Wengeback or an atrial flutter with an alternating 4:1 and 2:1 conduction can also produce bigeminy. Remember the different causes of bigeminy. The pulse could be absolutely irregular if there are random occurrence of frequent ectopics, or if there is atrial fibrillation. This was regarding the regularity of the pulse. Next is the volume of the pulse. The volume is the amplitude of expansile movement of the vessel wall. You have your finger on the pulse. What appreciates the volume is your middle finger. Of the 3 fingers that you are using to feel the pulse, it's the middle finger which is telling you about the volume of the pulse, which recognizes the amplitude of the expansile movement of the vessel wall. So you would refer to volume as normal, low, or high. And a quantitative measure of the pulse volume is the pulse pressure. A low volume pulse you would find in any low output state when the child is in shock, in severe aortic stenosis, or severe pulmonary hypertension. The defining feature of all these conditions is a low resting cardiac output. On the other hand, a high volume pulse you could see in aortic regurgitation, ductus, AV fistula, or in physiologic states like fever and pregnancy or thyrotoxicosis. The abnormalities of volume of the pulse, apart from being high or low, there are a few. Pulsus alternans and pulsus paradoxus, they merit special description. What is pulsus alternans? Alternating beats are of lower volume. This occurs when there is severe left ventricular failure. What happens is, in the lower volume pulse, the entire myocardium is not involved in contraction. As a result, there is a stasis in the next diastole, and this stasis stretches the whole myocardium and elicits a better stroke volume. This may be triggered by an ectopic beat. So remember, things are fine. Suddenly there is an ectopic beat. You would expect the volume to come down, and you would expect the next volume to be higher. In the absence of an ectopic beat, you would expect that this sequence ends and all the beats should have the same volume. But in pulsus alternans, that's not the case. Alternating beats continue to have lower volume, and that is the feature of pulsus alternans. Pulsus paradoxus is a different entity. It means the normal inspiratory decline of the pulse is exaggerated. It is elicited by checking the blood pressure. When you are, imagine that the blood pressure cuff is tied to the arm and you are listening. While listening, you find that initially you find the sounds intermittently, which means the sounds are heard only in inspiration, only in expiration. Later, as you start hearing in both inspiration and expiration, that means the lower value has been reached. So the initial value, when you heard the sounds intermittently, that is the systolic blood pressure in expiration. And the lower value, when you have the first sound, when you have started hearing the sounds regularly, continuously, that is the sound in inspiration. The difference between the two is the paradox. So you express it like, say, the blood pressure is 110, 100 by 80, the paradox being 10. And paradox is seen in causes that you are familiar with, like cardiac tamponade, constrictive pericarditis, or in non-cardiac conditions like status asthmaticus. The character of the pulse: rate, rhythm, character, volume, and now character. Abnormalities in character. Character is the distinctive feature of the pulse. A normal pulse, it is an upstroke. It is a peak which is sustained for a short while and a downstroke. The collapsing pulse is a high volume pulse with a rapid upstroke, ill-sustained peak, and a rapid downstroke. It is appreciated with the distal palm elevating you are elevating the arm and you are using the distal palm to appreciate it. And the causes of a collapsing pulse could be hyperkinetic states like fever, pregnancy, or anemia, or pathologic conditions like aortic regurgitation, patent ductus, ruptured sinus, arteriovenous fistula, truncus, systemic pulmonary shunt, or aortopulmonary collaterals. That's all collapsing pulse. A bisvariance pulse is a double beating pulse. When you say that it is double beating, it means both percussion wave and tidal wave are palpable. And the commonest cause is a chronic severe aortic regurgitation. Aortic stenosis plus aortic regurgitation or hypertrophic obstructive cardiomyopathy are also causes for the percussion wave and the tidal wave to be palpable together and to produce a bisvariance pulse. Look at some of these tracings. Look at the normal arterial trace, which is a fairly fast upstroke, little round at top, and then the dicrotic wave. And pulsus alternans where the character is the same, but the alternate beats are of lower volume. And bisvariance where on the peak you have on the upstroke you have two peaks. For the peak 1, peak 2, and then the dicrotic notch and the dicrotic wave. And paradoxus, character is normal, but you find that on a longer tracing, in inspiration the peaks are lower and in expiration the peaks are higher. So these are some of the common abnormalities illustrated. Other abnormalities include dicrotic pulse, when the dicrotic wave is palpable. This is a feature. This again will look like a double beating pulse, but the dicrotic wave, it happens when there is vascular paralysis. The normal dicrotic pulse is dampened by the normal arterial tone. If the arterial tone is lost, as in toxic fevers, in the past typhoid, in the present dengue, in these conditions, you can actually get the dicrotic pulse. Yet another named pulse wave abnormality is pulsus parvus et tardus, low volume, slow rising pulse with the feature of severe aortic stenosis. Anacrotic pulse is not felt, but it's seen in the arterial trace, especially from the ascending aorta. If you look at an ascending aortic trace before you are about to do a aortic balloon valvotomy, you will appreciate the anacrotic pulse. There is a notch on the ascending limb of the pulse wave. It is best seen in the ascending aortic pressure trace. You may feel it in the carotids. Now you have to feel the peripheral pulses. Palpate both the radials and both the pedals for sure. Asymmetry of the upper limb pulses, that is the one radial being stronger than the other, can occur due to a number of reasons. A pre-subclavian coarctation of the aorta. Your right radial is fine, left radial is weak. Takayasu's arthritis, depending on the subclavian which is affected, the corresponding radial is weak. Or if there is an aberrant origin of the right subclavian from descending aorta, that corresponding radial pulse tends to be weak. And if this is after a coarctation, of course it is weak. There is a less well understood, less popular entity called isolation of left or right subclavian. What happens is, in a pathology of fallow, the subclavian can originate from the ductus arteriosus. And as the ductus would be constricted, that subclavian would have a lower volume, the corresponding radial would have a lower volume. So either the left or the right subclavian could be isolated and could produce a weak pulse. In a tetralogy of fallow, therefore, when one radial pulse is weak, suspect isolation of left or right subclavian. In supravalvular aortic stenosis, the right upper limb pulses may be of higher volume. This is because the jet of supravalvular aortic stenosis, it follows the arterial wall and follows along the innominate arterial wall into the right subclavian and the right radial pulse. So you find that the right upper limb pulses are to feel they are of higher volume, and when you check the blood pressure, the systolic pressure is actually higher in the right upper limb. Sorry. And you are familiar with radiofemoral delay. A simultaneous palpation of radial and femoral pulses should be made, and you would find that the femorals are absent, feeble, or delayed in coarctation. Aortoarthritis and other causes of arterial occlusion would also be considered in context. For instance, you are seeing an elderly patient with weak femorals, the other pulses are also weak, then you think of atherosclerotic arterial occlusion. You are finding widely dispersed pulse occlusion in a adolescent and older patient, and then you could think of aortoarthritis. Remember, our sequence is pulse, blood pressure, and JVP. So having finished the pulse, you move to blood pressure. Recording blood pressure in children, there are different techniques. A sphygmomanometry with an appropriate pediatric cuff. The cuff specifications and all I'm not entering into. There is enough readily available literature on that. Remember the flush method to check the mean blood pressure in neonates. Oscillometry is the technique that is used in the non-invasive blood pressure recordings. And remember the Korotko sounds, where as you are deflating your inflated blood pressure cuff, phase 1 is the first loud sound, phase 2 is a soft murmur, phase 3 is a loud murmur, phase 4 muffling of sounds, and phase 5 disappearance of sounds. And pediatric hypertension would be diagnosed as blood pressure more than the 95th centile for age. I'm sorry. Now, jugular venous pulse. The jugular venous pulse is observed, and the jugular venous pressure is measured in the right internal jugular vein in older children and adults. In an infant, do not bother to look at it. You can feel the liver, and the degree of hepatomegaly is a faithful indicator of the central venous pressure in an infant. But in an older child or adult, you will look at the jugular venous pulse. The normal jugular venous pulse trace would have an A wave of atrial contraction and a V wave of ventricular contraction. It is an X descent, which shows the tricuspid valve descent, which is happening with RV systole, and a Y descent, which denotes right atrial emptying when the tricuspid valve opens. You may find an H wave, especially in constrictive pericarditis, when the passive filling of the right atrium is more prominent. Look at this trace. Here is the A wave. The A wave corresponds to atrial contraction. So it's a late diastolic event. Look at the cartoon. The atrium is in contraction. And the C wave, which often represents the carotid pulse. And you have the X descent, which is the descent of the tricuspid valve. And you have the V wave, which is related to ventricular systole. During the ventricular systole, the atrium is still filling, and you have the V wave. And then you have the Y descent as the AV valve is opening. See, the AV valve is opening here, and the next A wave comes as the atrium contracts. Some of the common abnormalities of JVP should be discussed. A prominent A wave, it occurs just before carotid. It's a presystolic event. That's how you recognize that it's a prominent A wave. You have your hand on the opposite carotid. As you're feeling the carotid, just before the carotid, you see the A wave. That's how you confirm that it's a prominent A wave. It's seen in severe pulmonary hypertension, especially with intact ventricular septum, as in primary pulmonary hypertension, or in severe pulmonary stenosis. These are the common conditions when the A waves are prominent. In tricuspid stenosis or tricuspid atresia, it may become prominent. Something that should be distinguished from a prominent A wave is a Cannon A wave. A Cannon wave is a systolic A wave. Remember, the regular A wave is a pre-systolic A wave. It's a diastolic event. So a Cannon wave is a systolic A wave due to atrial contraction against closed AV valves. It occurs with carotid pulse. You have your hand on the opposite carotid. You see the A wave when your hand is feeling the carotid pulse. That is a Cannon wave. Cannon waves may be regular or irregular. Regular you can get in junctional tachycardia with retrograde atrial capture, and irregular Cannon waves you could get in complete heart block and in ventricular ectopics. Classically, it's a feature of complete heart block, but ventricular ectopics could also cause it. The key pathogenetic feature is that the atrium is capable of contracting against closed AV valve. Normally, it doesn't happen. That is why you get Cannon waves in complete heart block or ventricular ectopics. V waves, when it is prominent, obviously it will occur with carotid pulsations, and tricuspid regurgitation is the prototype cause for prominent V wave. Why is it so? In the normal V wave, with the AV valve open, with the AV valve closed, the ventricle is contracting, and the normal V wave is because the atrium is filling passively. But in presence of ventricular systole being associated with a tricuspid regurgitation, during the ventricular systole, the RA is filling. Hence, you get a prominent V wave. It can also occur if there is an ASD with a mitral regurgitation. It can also occur if there is a Gerbodet defect when the LV is pumping into the right atrium. These are causes of prominent V waves, typically tricuspid regurgitation, because V wave becomes an active wave in that situation with the RV pumping into the RA. Kussmaul's sign is an inspiratory rise in JVP, which is seen with constrictive pericarditis. With inspiration, normally the intrapericardial pressure should yield, and the RA should yield, and the RV should yield. It does not happen so in constrictive pericarditis. So with inspiration, the JVP actually goes up. Having finished pulse, blood pressure, and JVP, you are now proceeding to precordial examination. You look at the shape of the chest. Is it caved in, pectus excavatum, protruding out, pectus carinatum, or is there a spinal deformity, kyphosis or scoliosis? Remember, all chest deformities can influence the position of the apex beat. In the precordial examination, you also note any surgical scar. And then you proceed to see and feel the apex beat. The apex beat is the lowermost and outermost point of definite cardiac pulsation. The Apex beat is best described after palpating it. You don't need to describe it as initially seen and then palpated separately. You look for the apex beat. If necessary, turn the patient a little to the left to locate it. The character should be described in the supine position. The normal character of the apex beat is when it lifts the palpating finger for less than a third of systole. It's described as tapping if you can appreciate a prominent first sound or a palpable shock of the first sound over the apex beat, as would happen in mitral stenosis. It can be called forceful when the palpating finger is lifted beyond the adjoining rib for more than a third of systole, where, as would happen in mitral regurgitation, aortic regurgitation, VSD, or ductus. It can be heaving when the palpating finger is lifted beyond the adjoining ribs for more than half of systole. A forceful apex beat lifts the palpating finger for more than a third of systole, heaving for more than half the duration of systole. So you feel the sustained lift of the hand. And you also describe double apex or triple apex when they in hypertrophic obstructive cardiomyopathy. You are dealing with different parts of the examination. So in case you want to ask any question at this point, I can pause for a short while. Would you like to ask me anything at this point? I'm waiting for any question to appear on chat. If you do not immediately ask, I am proceeding with the rest. And you can ask in the end. Other pulsations apart from apex beat, left parasternal pulsations would suggest RV volume overload. Left parasternal pulsations may extend up to the apex when the RV forms the apex as an atrial septal defect. Actually, now that I have started, please ask me the question in the end. I'll come back to you when I have finished. Left parasternal pulsations may extend up to the apex when the RV forms the apex. Pulsations in the left second space denotes enlarged pulmonary artery. Left parasternal heave denotes an RV pressure overload due to pulmonary arterial hypertension, valvar pulmonary stenosis with intact atrial septum. Epigastric pulsations, especially well seen in infants, denotes RV enlargement. Pulsations of the whole of the precordium in late systole denotes LA pulsations in mitral regurgitation, when the whole heart is rocking. Pulsations across the sternum, but not very forceful, that's a feature of RA pulsations in Epstein's anomaly. Powerful pulsations to the right of the sternum denotes aortic pulsations in Marfan syndrome, ascending aortic aneurysm. Now you move to auscultation. Before I start auscultation, maybe I'll take Achu's question. The question was pulsus paradoxus on auscultation. Explain, you have asked. Pulsus paradoxus is a feature of the pulse, or the how you appreciate it is, imagine you are just checking the blood pressure. While checking the blood pressure, how do you recognize the systolic blood pressure? You recognize the first palpable sound as you are deflating the sound, correct? As you are deflating the cuff, you get the first audible sound. You denote that as a systolic blood pressure. But then to your surprise, you find that you can't hear it as a regular thud. You hear it intermittently. Since you are hearing it intermittently, you keep your hand on the child's abdomen and you realize that the time that you are hearing it, the child is in expiration. In other words, when you don't hear, the child is in inspiration. As you are deflating the cuff further, you reach a point where this irregularity has disappeared and you can regularly hear the sounds. And the first beat with which you hear it is the systole in inspiration. So you have two systolic sounds for inspiration and expiration. You recognize the one in expiration when you hear it intermittently. You recognize the one in inspiration when you start hearing it regularly. The difference between the two is the paradox. I hope you understood it. Now coming to auscultation. While I am explaining, you can always chat in your questions. I may not answer it immediately, but at the end, I can take them together and answer also. Now coming to auscultation of the heart, you are listening for the heart sounds, the first sound, the second sound. The first sound, note the intensity. Second sound, always comment on the split, plus the intensity of A2 and P2. Is there any S3 or S4? Is there any other additional sound? Any murmur? These are the general principles of auscultation, or the points that you are looking for while you are listening. Now start with S1. S1 is related to the closure of the AV valves. The actual sound may not be generated by the AV valves. There are different theories on that. Again, you can easily read them up. The tensing of the chordopapillary structures as the sudden deceleration when the AV valve closure occurs is one of the common theories. And S1 is appreciated as a single sound because the interval between M1, the mitral component of the first sound, and T1, the tricuspid component of the first sound, is less than 20 milliseconds. There is always a delay between M1 and T1, but this delay is so short that our ear cannot appreciate this delay. Remember, human ear cannot appreciate something less than 20 milliseconds as separate events. Even 20 to 30 is difficult. More than 30 is when you can appreciate two distinct sounds. The other feature of first sound that you want to know is its intensity. Is it normal? Is it loud, soft, muffled, or are the different sounds varying? Between different cycles is the intensity varying? This picture you'll find in many physiology textbooks. I will not explain this in detail. It's worthwhile looking at this and trying to understand this. But this is the LV pressure trace. Once you're in the cath lab, you will appreciate it even better. Remember, this is the left atrial A wave, which is shown before the LV pressure trace, and the first sound occurs before the LV pressure starts rising, and the part of the systole from the first sound till the aortic valve opens is the isometric contraction, and then this pressure is superimposed on the aortic pressure trace. Then as the aortic valve closes, the systole is over, then the LV pressure is descending, and you have the mitral valve opening, which is happening here. That's the time when, if there is an S3, that will happen. And then the LV pressure reaches the nadir pressure or the dip diastolic pressure, which is 0 or below it, and then slowly builds up to the end diastolic pressure. That is the normal sequence of events in cardiac cycle. S1 intensity is governed by a few factors. One is the integrity of the valve apparatus, the position of the valve leaflets, the rate of rise of pressure within the left ventricle, the LV dP by dt, and the PR interval. I always compare this to a door that you are closing. If the door is good, made of good wood, not very old, it would produce a good sound. But that sound will also depend on where the door was when you started closing it. Was it fully open? From that position, if you are closing, versus if it was nearly closed when you started closing, one sound will be louder than the other. The full excursion would produce a louder sound. Then your hand, are you exerting too much pressure on that or too little pressure on that? That is the equivalent of dP by dt. These are the three determinants of the intensity of the first sound. The integrity of the valve apparatus, a fibrosed valve would produce, or a calcified valve would produce a dull first sound. The position of the valve leaflets, if the valve leaflets are far apart when systole begins, that will produce a loud first sound. If the the rate of rise of pressure is higher, that will produce a loud first sound. For instance, in mitral regurgitation, if the structural integrity of the mitral valve is unaffected, or in PDA, or in VSD when it is small, excellent ventricular function, you have a loud first sound. So you have loud first sound when there is mitral stenosis, tachycardia, short PR interval, VSD, PDA. You have a feeble first sound in acute MR or AR. In acute MR or AR, what happens is the LV-EDP keeps the AV valve leaflets near close position, so that with the onset of systole, the contraction pushes it closed only along a short distance. Viral myocarditis, dilated cardiomyopathy, acute MI, in all these instances, the rate of rise of pressure is affected. And varying intensity in complete heart block for obvious reasons. Ventricular tachycardia, because there is an AV dissociation. Frequent ventricular ectopics or atrial fibrillation. The S1 is split means you are able to appreciate the tricuspid component, because the mitral component contributes more than 80% of the intensity of the first sound. So if you can hear a split first sound, it means you are hearing the tricuspid component. You can hear it if there is a complete right bundle branch block, especially with an abnormally wide QRS complex or an Epstein's anomaly. The second heart sound, splitting, the inspiratory widening of A2-P2 interval is a feature of the normal second sound. Why this happens? There is an increased inspiratory venous return to the right heart, as you know, and this prolongs the right ventricular ejection and delays the P2. In inspiration, the RV has a bigger volume to handle and eject, and therefore the P2 is delayed. Plus, the pulmonary vasculature has a low resistance. Normally, you know that. And this low resistance of the pulmonary the pulmonary vasculature allows a longer hangout interval. What is the hangout interval? It's the time taken for the occurrence of P2 after the pressure crossover between the pulmonary artery and the right ventricle. The appearance of the normal split occurs in the later part of the first week. Split is not audible on day 1, day 2. By day 6, day 7, it tends to appear. And the normal A2 is best heard over the apex beat and the aortic area. The normal P2 is confined to the pulmonary area. The normal P2 is less intense than the A2 in the pulmonary area. If the P2 appears to you that it is equal or louder than A2, it's a loud P2. And a palpable P2 is always a loud P2. So these are some of the caveats with which you approach the heart sounds. And remember, when you are describing the second sound, you have to describe the split and you have to describe the intensity of P2. So to evaluate S2, splitting, normal, wide, fixed or paradoxical. And intensity is the comparison of A2 and P2. When do you say that the splitting is normal? The split widens in inspiration. It is better heard in supine position. It fuses in standing position. When you have a doubt about the width, you listen in quiet inspiration with the patient lying down. And if you have a feeling that it is wide, make the child sit up or stand up. If the split fuses and you are unable to hear the split now, that means it is normal. A wide split is of the same nature. It widens in inspiration. It's heard in both supine and standing position. But generally, a wide split is much less impressive in the standing position. A wide split may denote that the P2 is too late or that the A2 is too early. When the wide split is related to delayed P2, the causes could be mechanical or electrical. Mechanical, as in valvar pulmonary stenosis, Epstein's anomaly, atrial septal defect. either a structural abnormality of the valve or a abnormal contraction of the ventricle or a volume overload of the ventricle is delaying the P2. It is electrical when it is due to a right bundle branch block or its equivalence that can happen. You have RBB equivalence in left ventricular pre-excitation. The axillary pathway is inserted into the left ventricle, so the LV which contracts first. If you're pacing the LV, same thing happens. If there is an ectopic beat arising from the LV, during that ectopic beat, you have a widely split second sound. So these are all delayed P2 as causes of a wide split. Early A2 means you have an extra smart left ventricle. The left ventricle completes its ejection earlier than expected. This happens with a mild mitral regurgitation or a small ventricular septal defect. There is a diastolic stretch, normal ventricular contractility, so that ventricle exhibits a very vigorous contraction. Why mild and small VST, mild MR and small VST? Once MR becomes severe or VST is large, the left ventricular function is unlikely to remain normal. It may be impaired. Fixed splitting is the other term that you often hear. It means the split is audible with the same A2-P2 interval in both inspiration and expiration. And why do you hear a fixed split? In atrial septal defect, the prototype cause for a wide fixed split, the inspiratory increase in right heart filling is offset by the proportionate decrease in left to right shunt across the ASD and vice versa in expiration. What it means is the RV with inspiration you expect to fill more, but then in inspiration, as the RA is containing more inspiratory blood, the left to right shunt would decrease. So as far as the RV is concerned, the contribution from the left to right shunt is decreased, and in parallel you have an increase in the inspiratory return. In expiration, ordinarily the filling would have come down because the venous return is decreasing, but now the left to right shunt is increasing. So the RV is receiving a fixed input and the RV output is also fixed. This is the reason why in ASD the split is fixed. Remember, this can also happen in severe right ventricular dysfunction and constrictive pericarditis. This is because the right ventricular output is fixed due to the inability to increase the output further. In constrictive pericarditis, the extent to which it can relax is limited. So regardless of what is happening to the respiration, the output remains fixed. So the A2-P2 interval remains fixed. If there is severe right ventricular dysfunction, same thing. Whatever is the inspiratory variation, this poor ventricle is unable to increase its output. You now hear the word paradoxical split. Paradoxical split is a term that you use when the split is wider in expiration. When you hear the second sound, you hear the split, but have your hand on the child's abdomen in quiet respiration, and you realize that when you are hearing the split, the child is not in inspiration but in expiration. And just like the other conditions, here you can split the causes as electrical and mechanical. Electrical would be left bundle branch block, right ventricular pacing, right ventricular pre-excitation, and right ventricular ectopic. In all these conditions, the right ventricle starts beating first. Mechanical, when there is a problem with the aortic valve, severe aortic stenosis or left ventricular dysfunction, especially in hypertension, you can appreciate a paradoxical split. Single second sound a single second sound is due to a fused A2-P2 combination or absent A2 or P2. The fused A2 and P2 both are present but they are fused. It's a feature of Eisenmenger VST. Absent P2 would occur in pulmonary atresia, absent pulmonary valve, or if you have an abnormal position of the pulmonary artery as in transposition, either complete transposition or corrected transposition, the abnormal position of the pulmonary valve and the pulmonary artery makes the P2 inaudible to us. Absent A2, aortic atresia or calcific aortic stenosis. Truncus arteriosus, you have a distinct situation where there is only one valve to begin with. And in corrected transposition, in my last lecture on corrected transposition, I pointed out that the single second sound is louder in the pulmonary area. So in a casual auscultation, you tend to think that the P2 is loud, but it's a single sound. It is palpable in the aortic area, and it's palpable in the pulmonary area. This denotes the abnormal position of the aorta, which is L-post. Now we come to the third heart sound. The S3 is a low frequency sound that is attributed to the shudder of the ventricular myocardium as it changes from a rapid elongation to a slow elongation in diastole. Now what it means, the S3 relates to the lowest point in the Y descent. As the blood is gushing into the ventricle, how does the myocardium behave? The myocardium is relaxing rapidly, and in the phases of diastole, you know the rapid relaxation and the rapid filling and the slow filling. If you look at it from the myocardium's point of view, it's a rapid elongation and a slow elongation. It is during the transition from the rapid elongation to the slow elongation that an S3 is heard. What produces the sound? There are conflicting theories, but the most widely accepted one is that it is a shudder of the ventricular myocardium when this transition is occurring. It's a mid-diastolic event for sure. It occurs about 150 milliseconds with normal heart rate from A2, and it depends on a few factors. The interesting thing about S3, it can be there as a physiological event in the young child. A 5-year-old child, and S3 is normal. A 50-year-old man or woman, the S3 is always abnormal. So any explanation for the genesis of the S3, we should be able to reconcile this apparent conflict. The intrinsic property of the ventricular myocardium is the reason why in a child the S3 is heard as a sign of normalcy. When the ventricle relaxes, the intrinsic property of the ventricle, the ability to relax quickly, is a pediatric feature. You will hear it in a child. It is lost as the child grows older. The ventricle would become relatively stiffer in the normal healthy myocardium of 40 or 50-year-old. So the intrinsic property of the ventricular myocardium is responsible for the physiological S3. On the other hand, if the transition from the rapid elongation to the slow elongation is occurring at a higher filling pressure, what is the filling pressure? It is the left atrial mean pressure or the right atrial mean pressure for the right side. If the filling pressure is elevated, then again the sound is generated. If the AV valve is normal and the filling pressure is elevated, you hear the sound. That is why left ventricular failure or right ventricular failure generates a third sound on the appropriate side. Now all these are okay, but there is an increased flow and there is a greater volume which is distending the ventricle when this elongation rapid to slow shift is happening. That is the reason why you get a third sound in mitral regurgitation, aortic regurgitation, ventricular septal defect or ductus arteriosus. In all these conditions, the common feature is a greater transmitral flow. And this greater transmitral flow distends the myocardium, and the rapid elongation to the slow elongation becomes faster, becomes more active. And that is the reason why you hear the third sound in these cases. So the seemingly conflicting occurrence of S3 in the normal heart and then it becoming abnormal in the older person's heart, that is explained by these mechanisms. Now we move to the fourth heart sound. Unlike the third sound, the fourth sound is never normal. Repeat, fourth sound is never normal. It's a relatively high frequency sound It occurs due to the shudder of the ventricular myocardium due to late diastolic filling from atrial contraction. It's always pathological and it denotes reduced compliance of the ventricle. And the causes would be on the left side, hypertension, aortic stenosis, coarctation, hypertrophic cardiomyopathy. The common feature is a hypertrophic left ventricle. The reason why the S4 is heard, the left atrium has to contract more powerfully. And on the right side, the right ventricular pressure is elevated either due to pulmonary stenosis or pulmonary hypertension, and then you hear a right-sided fourth sound. How do you recognize a fourth sound? After all, we can only hear two sounds in close proximity, which sounds like a split S1. S4 is very close to S1. Then your problem, is this an M1T1 or if it is an M1T1, remember the T1 is heard in the tricuspid area. A left heart, left-sided fourth sound is heard over the apex beat. A palpable sound over the apex beat is a fourth sound. If it is an S1 and an ejection click, then again you can get a problem. The ejection click follows the first sound, and you are hearing what looks like a split first sound. Here, the click is sharper and it is louder and it has no respiratory variation. It's a constant click, as we will explain later. The S1 click, the click heard over the apex beat is a constant click. So there is no respiratory variation and the click is sharper. Remember, the left-sided S4 is best heard in expiration and the right-sided S4 is best heard in inspiration. Now we come to clicks. A phasic ejection click is a feature of valvar pulmonary stenosis. What causes a phasic ejection click is the abrupt cessation of the doming movement of the pulmonary valve. Remember the pulmonary valve appearance in echocardiogram. It is doming. The valve has a range of movement from where it starts to open to the point of the maximum excursion of doming. So the domed valve is shuddering, and the abrupt stopping of the opening, that is the thing which is generating the click. This click is louder in expiration, and this is the only right-sided event that is loud in expiration. Remember, a phasic ejection click of valve RPS is the only right-sided event that is louder in expiration. Everything else would be louder in inspiration. The doming pulmonary valve will be pushed to a near open position end diastole in inspiration because of the high RV filling. So its subsequent opening is across a short distance, and therefore you hear an unimpressive click. Whereas in expiration, as the RV filling is much less, there is a greater range of excursion of the opening pulmonary valve, and that is the reason why you have a louder click. And the more severe the valve RPS, the click fuses more and more with the first sound. So in severe valve RPS, the S1 is, you have the superimposed click on that. What looks like a prominent loud S1 in pulmonary area, remember, a simple S1 has no reason to be loud in the pulmonary area. So there's something wrong with it if you're hearing it in the pulmonary area. And when you listen to that, you realize that it is louder in expiration. That is how you would recognize the phasic ejection click in severe valve RPS. If there is severe pulmonary hypertension, you can get a constant click from the dilated pulmonary artery, which is a vascular click. So a constant click denotes a doming bicuspid aortic valve. The click is constant, unlike the phasic ejection click of valve RPS, because the aortic diastolic pressure is a substantial figure. The pulmonary artery diastolic pressure is 5 or 10. The aortic diastolic pressure is 50 or 60 or 80, depending on the child's age. And this diastolic pressure does not allow phasic variations in left ventricular volume to influence the position of the aortic valve. So the opening of the aortic valve, as the valve cusp reaches the maximum doming position, it shudders and produces the sound. LV volume cannot influence it, opposing the impressive figure of the aortic diastolic pressure. And a constant ejection click is best heard over the apex beat and aortic area. And you have to distinguish it from S1, S4, we already said, and M1, T1. This is a loud, sharp sound without respiratory variation. Other sounds, you have the vascular clicks in dilated aorta or dilated PA. You can hear them in idiopathic dilatation of the pulmonary artery or in any cause for pulmonary hypertension from the pulmonary artery, or the dilated aorta in tetralogy of Fallot or in hypertension. These are causes for vascular clicks. Remember, you have multiple clicks in PDA, in long ductus. What happens is a long and tortuous duct. There are eddy sounds which are generated from the vascular wall, and this is the reason for the multiple clicks that is heard in PDA. Non-ejection click is a feature of mitral valve collapse. Dynamic variation is a feature of this. A small left ventricle and early click. A small left ventricle will produce an early click. Therefore, when the person stands up, you have a prominent click and an early occurrence of the click, and a larger LV as when the child is lying down. It delays the click and shortens the murmur. The other event that you may hear is a pericardial rub, which is a triphasic, superficial, leathery sound. Now we come to murmurs. The murmur should be recognized for its timing, grade, pitch, character, respiratory variation, and context. A systolic murmur is classified as pansystolic if it extends from first sound to second sound, as you would hear in VSD or mitral regurgitation, or early systolic if it begins with S1 but ends before S2. You would hear quite often in a small muscular VSD, the systolic murmur begins with S1 but it does not reach the second sound. It can also be early systolic in a large VSD, because in a large VSD, in the later part of systole, LV and RV pressures are equal, and therefore you don't hear the murmur. In acute mitral regurgitation, in late systole, LV and LA pressures equilibrate, and therefore you don't hear the murmur. It's all early systolic beginning with S1. Ejection systolic will begin an interval after S1 and end before S2. So there is a gap between S1 and the onset of the murmur, and there is a gap between the end of the murmur and S2. Classic features of AS and PS. In late systolic, the initial part of systole is free. Later part, the murmur appears. It's a feature of mitral valve collapse and mitral regurgitation. Diastolic murmurs, would be called early diastolic if it begins with A2 or P2. If it begins with A2, it's a classic feature of aortic regurgitation. Beginning with P2 is what you would hear in the Graham-Steele murmur of hypertensive pulmonary regurgitation. It can be a delayed diastolic murmur when it begins an interval after P2, simulating a mid-diastolic murmur. A non-hypertensive pulmonary regurgitation, which you hear so commonly after tetralogy repair, is a delayed diastolic murmur. A mid-diastolic murmur has an interval between the second sound and the beginning of the murmur, and this would also end before the next first sound. Typically mitral stenosis, tricuspid stenosis, flow murmurs of ASD across the tricuspid valve, MR, VSD or PDA across the mitral valve. The pre-systolic murmur is mitral stenosis or Austin-Flynn murmur are pre-systolic murmurs. A continuous murmur begins in systole and runs across A2. That's a feature of PDA. Grading of murmurs, Levine and Harvey graded the systolic murmur. Currently, both systolic and diastolic murmurs are graded by American Heart Association. The original Levine and Harvey grading was only for systolic murmurs. The diastolic murmurs are graded 1 to 4. Grade 1 of systolic murmur is heard only on intense auscultation. Grade 2, it is readily audible. Grade 3, it is still louder but there is no thrill. Grade 4, it is loud with a thrill. Grade 5, it is still louder, and grade 6, you can hear it with a stethoscope slightly removed from the chest. The pitch and character of the murmur also should be noted. A low-pitched murmur is a feature of mitral stenosis, like 25 to 125 cycles per second. A medium-pitched murmur, 125 to 300 cycles per second, sample innocent murmur. A higher-pitched murmur, more than 300 cycles, is a feature of AR or MR. The pitch is related to the pitch and character are sort of interrelated features. You have the blowing murmur of aortic regurgitation, the musical murmur related to caudal rupture, the machinery murmur of PDA, the honking murmur of mitral valve collapse. This picture illustrates some of the common phonocardiograms. Here the normal, the first sound, second sound, the ejection systolic murmur of aortic stenosis, the pan-systolic murmur of mitral regurgitation, much less intense, the long early diastolic murmur of aortic regurgitation, the mid-systolic murmur of mid-diastolic murmur of mitral stenosis with pre-systolic accentuation, the continuous murmur of ductus. Remember to describe respiratory variation, where right-sided murmurs increase with inspiration, left-sided murmurs increase with expiration. The site of maximal intensity of the murmur, aortic area, aortic stenosis, aortic flow murmurs, pulmonary area, pulmonary stenosis and ductus, tricuspid area, tricuspid regurgitation, ventricular septal defect, TS if it's diastolic, apex, MR, aortic stenosis, mitral stenosis, back, coarctation, peripheral pulmonary artery stenosis, pulmonary AV fistula. And describe conduction. Conduction is a selective propagation of a murmur with the same or greater intensity. Example, aortic stenosis, where it's heard and conducted to carotids. Mitral regurgitation, heard over the apex beat and conducted to axilla and back. You have innocent murmurs, the vibratory murmurs of Still's murmur, venous hum from jugulars and brachiocephalic veins, pulmonary systolic murmur, thin chest wall and straight back, peripheral pulmonary murmur from pulmonary branches. You use the word bruit when murmurs are heard over extracardiac location. There are no hard sounds for timing, so you call it a bruit. Example, a carotid bruit in carotid obstruction. In coarctation, you speak of a bruit in the left interscapular area. Or the femoral artery, if the femoral artery is obstructed, you may get a bruit. These are some of the common sounds that you hear and describe. Now, I'll just go on to describe a common case presentation to say what is expected from you. Ajmal, a 10-month-old boy infant, one of twins, born of consanguineous marriage, was found to have a heart murmur on routine examination. Birth history, birth weight 3.25 kg, baby cried immediately after birth, did not stay in the NICU. Family history, no history of congenital heart disease in the family. The younger twin is a 10-month-old girl and she's doing well. Immunization history is complete. On examination, a healthy looking baby with weight, length, head circumference which are normal. Pulse is 100 per minute, regular, bounding, upper limb pulses and lower limb pulses are not felt. Right upper limb BP is 140/80 and left upper limb is 150/80. Lower limb 60/40 and 50/40. CVS, there is apex beat in the left sixth intercostal space outside the midclavicular line, heaving in nature. No parasternal heave, no thrill. The first sound is normal. Second sound is closely split. P2 is normal. There's a constant ejection click. There's a grade 3/6 ejection systolic murmur over the aortic area and the apex. Bruit over the upper left interscapular area. Air entry is bilaterally equal, vesicular sounds, so your diagnosis is obvious. But you describe it as S-cyanotic congenital heart disease, cytosolitis levocardia, post-subclavian coarctation of the aorta with bicuspid aortic valve, systemic hypertension, and heart failure. So the different parts, the group of the diagnosis has been mentioned, the actual diagnosis has been mentioned. This is how you would describe a history. I would stop here. The two things, please feel free to ask questions. Second, on